Good afternoon, everyone. It's just turned 1 o'clock, so let's get started. My name is David Bramley. I'm Deputy Director for NHS at Home in NHS England and Improvement. NHS at Home aims to bring personalised, connective and supportive care to people's homes, including care homes. And today we're going to talk to you about COVID Oximetry at Home, which is part of that. And I have the privilege of chairing this meeting today. So I'd like to start off by thanking you for your time this afternoon. I appreciate that everyone is incredibly busy, incredibly stretched and doing an incredible job. So we're going to try and use your time judiciously. I'm going to try and keep the intro brief so that we can get to the main parts of the meeting. And we're also aiming to give around 25 minutes for your questions. We've had so many people want to sign up that we've reached our capacity on Teams. It's fantastic, but the drawback to that means that some people have not been able to join today who want to. So we are going to record the webinar, so it's available for people to view afterwards. As I mentioned, we encourage you to ask questions in the chat throughout. And if you can double check you're on mute and turn your camera off if you're not speaking, that would be fantastic. We will take those questions at the end of the session. For anyone watching the recording of the video now, if you have any questions that we don't cover, you haven't missed your chance. Please do email us afterwards, get in touch. You'll see as we go through the presentation, there are contact details. Could I have the next slide, please? So actually, just before I get to that, just to describe the agenda to you. So what we're going to do is I'm just going to cover some of the basics around COVID Oximetry at Home. Then Adrian Hayter and Kay van der Sloot, as a GP and a registered manager, will talk to us about COVID Oximetry at Home in the context of the care home and what it means for staff, for residents and for families. Then Alison Taveri is going to talk to us about the support and training resources that are available, including those that are tailored specifically for a care home audience. Bree O'Brien will then talk to us about tech-enabled support available, and John will talk to us about the rapid evaluation of oximetry in care homes. We were hoping to have someone here from CQC. Unfortunately, that's not been possible. And I know we've had some queries from people regarding whether COVID oximetry at home is a regulated activity. We have confirmed with CQC that COVID oximetry at home is not a regulated activity. And they'll also be communicating this further with inspectors. We understand that some inspectors have applied a different interpretation, so obviously it's important to have consistency and pragmatism. So lastly, we'll go into questions at the end. As I say, we'll aim to keep around 25 minutes for that. Please do ask questions in the chat. Joe will keep an eye on these. We'll then try and group them, identify common themes, and we'll answer as many as possible today. If there's any that we can't answer through time because we need to go away and find out additional information, we will take that offline and come back to it and make sure you've got the answer to your question. Okay, so in terms of a brief introduction, I'm just going to cover some of the fundamentals, and I appreciate some of you will be familiar with this already. So firstly, what is silent hypoxia? Well, it's often talked about in the media as happy hypoxia, but essentially it's when oxygen levels in the blood drop to dangerously low levels without a person noticing. So this is one of the unusual and also dangerous features of COVID. And our aim is by identifying this earlier through pulse oximetry, we can then help people get the treatment they need faster and reduce length of stay and also help improve survival. So COVID oximetry at home is an approach for this to happen by providing pulse oximeters to people most at risk of COVID and supporting them or the carers to monitor their blood oxygen levels and escalate appropriately if these levels decrease. And importantly, at home includes care homes and people's general usual place of residence. If you haven't seen one before, sorry, I'm just seeing that there's a comment that the slides aren't visible. Bernard, if we could perhaps reshare them and just see whether they pop up, that would be really helpful. Especially for this next point, as I was going to describe what an oximeter looks like, given I've got a picture of one on the slide.
I think, David, we can see most of this. Most people can see the slides. So it might be
okay, fantastic. Thank you, Adrian. And I can see Kerry's replied as well. That's good. So in terms of a pulse oximeter, you can see one on the picture on the left on the side. So it's a simple device. It clips onto the end of a finger. And the picture that's shown is from a recent BBC article. And oximeters are essentially another important tool in the tool bag to help reduce the impact of COVID. At the moment, we are focusing on people who have COVID, who are symptomatic and 65 or over. Alternatively, we're also including people who are clinically extremely vulnerable. But we know that many areas are going further than this, and we're actively considering whether to extend the entry criteria. So we're considering whether it's 50 and over, and also strengthening clinical judgment. So that would align us with the Joint Committee on Vaccination and Immunisation Phase 1 recommendations, cover 99% of people, or 99% of mortality from COVID. And it would also encourage it to include other important groups which may not be covered already, such as people with a learning disability, where there can be an up to 6 times greater risk of mortality from COVID. To support this, we've procured a national supply of oximeters which conform to the latest ISO standards and are CE approved. For care homes in particular, we recommend 1 oximeter per 10 beds with a minimum of 2 per home. So if you don't have enough oximeters in your care home or care homes, then we'd recommend you get in touch with your primary care network clinical lead. Lastly, from me, we've also asked every acute hospital trust to establish what we call a COVID virtual ward. These support early and safe discharge from hospital rather than people. What we've described in COVID oximetry at home is about putting support around people who may be at greater risk of going to hospital. So this is about discharge. In practice, the boundaries and the names between COVID virtual wards and COVID oximetry are often blurred locally, which is no bad thing necessarily. I think the important things here are to note that this doesn't change any current discharge arrangements for care homes. And it's important that your care home has sufficient oximeters and are getting the support that you require. Thank you. Appreciate that's a whistle-stop tour through the basics. At this point, I'll just highlight our email address at the bottom of the slide. If you do have any further questions, please do get in touch with us. And without further ado, I'll hand over to Adrian and Kay.
Hi everyone, my name's Adrian Hayter. I'm a GP in Windsor and should be joined by Kay, who I noticed was in there. Kay, do you want to turn your camera on?
My camera is on. Lovely.
Thank you, Kay. So Adrian Hayter, I'm a GP in Windsor. I've been I suppose supporting the manor for probably maybe about 7 or 8 years. Kay, would you say that that's about right? So so really kind of we've been working as a practice at the Runnymede Medical Practice for quite a while, supporting the residents in the manor in Old Windsor. And my other role is as National Clinical Director for Older People, and as part of that I'm supporting the NHS at Home programme and this specific element. So Kay, did you want to introduce yourself?
Hi, good afternoon. My name's Kay van der Sloot and I'm the registered manager at the Manor Care Home in Old Windsor, and Adrian Hayter is our GP who looks after the staff and the residents here.
Thank you. And Kay, we've been obviously kind of working throughout this pandemic fairly closely together, haven't we, in terms of trying to support the residents. And I know that this morning we've had a little outbreak of some of the residents who have developed COVID. So I'm really grateful for your time, because I know that you and the staff there at the Manor are working tirelessly to be able to keep on top of everything that's going on, right from the beginning of the pandemic, when we were looking at kind of PPE. And I know that we were sharing PPE, weren't we? Or kind of, you know, when you had stocks of PPE and the practice were running short, you were loaning us some of that in terms of some of the hand gel, and then we were reciprocating sometimes with masks and things like that. And that relationship has been really important, I think, for the residents to be able to protect them as best we can and be able to adapt over these last few months. So grateful for you and your staff, and for taking the time out really today to kind of share some of our experience in the Manor during this time. But pre-COVID, I just wanted to take us back to before COVID. And the way that you have been supporting the staff at the Manor to be able to use some of the devices. And I know that you have nurses, but you have care staff at the Manor who have been trained to really support the residents by doing some simple observations. The things that we were doing before COVID were to use blood pressure monitors, to use temperature, to use pulse, and to use oxygen saturation as a way of identifying patients who may be more ill than we would recognise, and we built up a language about that, didn't we, Kay? Did you want to just describe how we started to do that?
I think initially, the key information that yourself as a clinician required from us over the telephone was to be able to communicate effectively and actually present the resident if you weren't on site. So it was key that we were using manual blood pressures, the pulse, describing the pulse to yourself, and also the oximetry readings were paramount, and that we were then referencing the news score, which now is just mandatory throughout, and so that any observations, oximetry is part of those readings that are documented and part of the vital signs.
Yeah, and I think it's been really good how, I suppose, you know, through some of your leadership within the home, you've supported the nurses, and we've done that together as well on the ward rounds in kind of creating this language, so that if you ask one of your staff, they know what the news score is about, and they know how to act, and they know how to use it in a great way. So in some respects, before the pandemic, we were lucky to be in a situation to be able to have the equipment to hand and to use it in that kind of way. But I just want to cast our minds back to probably about March 2020, when the pandemic was just kind of coming in, and we were learning about that in the home. And I remember a time when I went in to kind of see some residents who were ill, and one of your staff, Kelvin, actually, who's a great nurse, at the end of the ward, at the end of the round, when I'd gone round to see the people who they thought were ill, he said to me, "Oh, do you mind just seeing a resident who has a rash?" And obviously, he didn't think that was an urgent thing, but it was while I was there, he wanted me to go and see this resident. And so when I went to see the resident, and he took me to see her, I remember she was sitting in bed, and she wasn't she didn't look unwell at all. And you can spot sometimes when somebody looks unwell. She didn't look unwell, and I thought, well, where's her rash? What's the issue? And he withdrew the bedclothes, and there was a rash on her legs, and the rash was a mottled rash. And what I mean by a mottled rash, it was a rash where her legs looked poorly perfused. They didn't have a lot of oxygen going to them. And so for me, that was a kind of a real moment of kind of understanding that this person might be really unwell. And Kelvin hadn't done the oximeter. She hadn't used the pulse oximeter at that stage, but we did, and her oxygen saturations were about 83, which was very low. and for us that meant that she was seriously unwell, and we were able to have a very quick conversation with her family, and her family came in actually, and we spoke to them about her and about the plan, and we agreed the plan for her to stay in the care home, but she died the next day. I don't know whether you remember that resident, but for me it really emphasized this point around silent hypoxia.
I certainly remember it vividly. And I think the need to be so vigilant on the observations visually, but also using the oximetry, and especially with COVID, that it's a key indicator and an assistance to actually recognising how potentially ill this resident could be or become. And I think sorry.
No, go ahead.
No, and just setting up a red flag that your observations are not just done once. You're going to be doing them 2, 3, 4 times a day until you can actually see either somebody stabilising or deteriorating further and escalating it.
Yeah, and I think it's having that ability, and obviously when we're also able to have good conversations at an early stage with residents and their families, to be able to make good decisions for their care. And I think that's partly what we want to do, is to make those early decisions, to understand what their care plan is and to be able to act on that. And bringing us forward to today, when we had our ward round today, Kay, we were talking about individuals who were through our regular testing that we've been doing, were picked up with COVID, but also what that's enabled us to do is to strengthen our infection control measures. So we've actually looked at, although our infection control measures in the home were really good, you've gone into a phase of doing more cohorting, so that staff and residents are kept in a bubble, if you like, and we're able to enact some of the measures around COVID oximetry at home, which are to set up some regular pulse oximetry, so the staff will be measuring oxygen saturations. And we had a conversation this morning, and Wednesday's my day when I'm not in clinical practice. But Kay said to me, "Do you mind if we notice any deterioration coming back to you on a Wednesday?" And I said, "Absolutely not. We're here to support the residents, and we're going to be able to observe them over the next few days, just to make sure that we can treat and keep on top of this COVID disease." And I think that's partly the important element of this, is actually knowing, understanding, and doing all that we can to be able to support the residents in this type of care. So Kate, just in terms of what that means to you and the staff going forward around oximetry at home, any last points?
I just think the pulse oximetry is invaluable. It is also reassuring to the residents as well, and communicating with them. I think the staff are now far more confident at using these tools, and it's just a huge asset to have in the home, and of which we have about 8 or 9 that can be given or to dedicated residents, as is the ones now that are COVID positive. They have their own pulse oximeter in the room as well to aid IPC as well.
Yeah, thank you. And so yes, so there's some protocols around decontamination and all the other things, but actually, we've been able to purchase more in the home and be able to use those dedicated ones for the people who are COVID positive. So thank you very much, Kay, for that conversation. I think kind of it underlines and kicks us off to this meeting around the importance of using COVID oximetry at home. I'm going to hand back to David now.
Thank you, Adrian. And I'm immediately going to hand over to Alison Teferi, who's going to talk to us about learning resources that are available. Alison.
Thanks very much, David. And thanks very much, Adrian and Kay, for putting it in context and why measuring oxygen levels in the home can be so useful and provide better outcomes for our patients. So as a bit of background, I'm a GP, but I'm also regional clinical lead for COVID oximetry at home. But alongside this, I'm a clinical lead at the West of England AHSN, and for some years we've been collaborating with our care home colleagues to support the rollout of Restore 2. And again, as part of that, we've worked with Wessex AHSN and West Hants CCG to develop some videos to support this work. And we've had over 200,000 views. So if you haven't seen them, I know that Joe can put a link into the chat. Next slide, please. And so using, because of the videos, that really started the conversation about how can we support you as carers looking after our patients who are unwell, and how can you measure oxygen levels, particularly when it's not something you may have done before. So it's a group of us, Emma Self, who's on this call from the extended healthcare in care homes, and Danielle Fullwood from Health Education England. Together we produced this resource. It's a very short e-learning package, and really it can be just used as a basic starting pack if you're asked to look after somebody with COVID and monitor their pulse oximetry. And so in about 10 minutes, the hope is that you can get an overview of why you need to measure someone's oxygen levels, how to do it, how to record it, and what you should do if somebody you're looking after becomes unwell. And so the link's at the bottom of the page, but again, we can put the link in the chat. The package can be opened up on your computer, or it can be opened up on your phone. And if you choose not to reload it, it means it's always there. So it's quite easy for reference. Next slide, please. So that's kind of the quick start way of using it, but I'm sure I'm not alone that if I'm looking after somebody with a clinical condition I've never seen before, I need to look at things quite a few times to make sure I understand it more. And so the quick start is about 10 minutes, but we've also put links to documents within it. So documents to help you when you're handing over patients within the team, so others know that you're looking after somebody, monitoring their oxygen levels. We've also put a sheet there on how to do SBOD, how to communicate if you're telling the out of hours service that you're worried about somebody. And we've also got a number of videos. They're about 3 minutes long. They've been co-produced and they cover things like how to measure someone's oxygen levels. As you can see from this screenshot, it's also possible if you look on the settings to translate it into numerous languages. It is with Google Translate, so it may not be perfect, but it is there. And other videos include soft signs and also how to support communication. So that's added learning. But the third use, and I think in many ways, particularly again as a clinician, the value is what to do in an emergency. When you're a carer looking after somebody, you're by yourself, it's the middle of the night and you can't quite remember what to do. And if, as I say, you've got it open on your phone, it can just remind you. You may well have a number that you've been given to call, but if you see these two icons, you can click on them and it'll give you some advice on when you should seek help. So I hope that's just a quick overview of those resources so that you can check, you know, how to get started, how to monitor somebody and what you should do if you're worried. Next slide, please. David mentioned the CQC because we've actually had lots and lots of questions regarding the CQC, and I've just included this slide so you can actually look at the document, the scope of registration. I think it's page 41 I took the quote from, basically saying that the physiological tests not included within registration include pulse oximetry. So I hope that's reassuring for people. If you've got any more questions, we've put the inquiries at the CQC link on the bottom of the slide, but hopefully that will provide reassurance to you. Next slide, please. So that's the work that we've the support we're providing with the Health Education England and NHS at Home. But I also work with the HSN network, and for those of you who aren't familiar with the HSNs, there are 15 across the country, and the aim when they were set up in about 2015 was to support the adoption and spread of evidence-based interventions in health and social care. But the remit's widened, and each HSN network has a patient safety collaborative within it, and these patient safety collaboratives are supporting the rollout of COVID Oximetry at Home. So you can see there that you will have a local AHSN network Patient Safety Collaborative in your area. So do feel free to contact them for some help. Next slide, please. And as I said, the help can be personal, so therefore also local to you through the collaborative. But there's also national help. And the Future NHS Collaboration Platform is an absolutely fantastic resource, and Joe Murray, who's going to moderate the Q&As, has been really instrumental in helping us to collate the information. Two main areas to highlight: one's NHS at Home, with lots of national guidance and information, but also the National Deterioration Forum. There's a really good discussion forums. If you're not sure on something, ask a question. We also have monthly National Learning Network meetings, which I personally find invaluable, lots of discussion. And if you think, well, I don't know if I'm able to join it, I'm not an NHS organisation. I know Breeds are going to talk soon about digital, but if you've got an NHS net address, you can register for this. Next slide, please. So I hope that's just given you a brief overview of what resources are available with the e-learning package, which can help you get up to speed on monitoring for pulse oximetry and how to communicate concerns. There's also, as I say, the offer from the HSNs to help support you, and hopefully before too long COVID will be less of an issue for us, and going forward the HSNs are working actively to support care homes, particularly with the framework for enhanced health in care homes. So contact them now, but be aware that you can contact them in the future to help you in your work. So I hope that's just a quick overview, and I'd now like to pass back to David. Thanks very much.
Thank you, Alison. That's really helpful. And just before I hand over to Breed to talk about tech support, just a reminder, I think Kerry's posted in the chat as well, but if you have any questions, please do post them in the chat, and we will do our best to get through all of those. We've been a little bit quiet so far. People may be reflecting, but if there's something on your mind, please do ask, and we'll be happy to help. So Breed, do you want to take us through the tech support available through NHSX?
Yeah, thank you, David. Hi, everybody. I'm Breed O'Brien. I'm the Deputy Director of Digital Health at NHSX. Next slide, please. Just for background, from last year, we set up a programme of work which is called our Regional Scaling Plans and Innovation Collaborative. And it's essentially to enable remote monitoring tools and platforms across the country. And every one of our regions have implemented some form of this within the care home system. So this slide just outlines the products that are being used around the country that we are aware of. There may be others. Many of these products support remote monitoring, and as the focus of today is on how do we the early detection and management of silent hypoxia, all of these remote monitoring solutions allow you to record, when you record your pulse oximeter, to either enter that into the system or it's done automatically. You can easily provide COVID Oximetry at Home service without these technology platforms. The advantage of them is that they do allow anyone reviewing numerous patients or numerous residents to see the variation, and obviously equally to see any deterioration, because you do see sequential recordings. They're not essential, but I guess the message is we have been supporting the care sector with remote monitoring platforms, really eager to talk to anyone who would like any further information. And I've popped our NHS Future site and our email address in the chat. And early feedback has been that, I know people have talked about news and other broader measurements, is that actually the collation of these measurements has allowed people to get quicker reaction from a clinical perspective, but equally to have better conversations and pick up early deterioration earlier. I'm going to stop there and hand back to David, but yes, please do get in touch if we can help in any way.
Thank you, Breed, and thanks for the offer of people getting in touch with you, and I'm sure that applies to all our speakers today as well. I'm going to hand over to our last speaker, John Sussex, who's going to talk to us about research and evaluation, and we're really keen to ensure that we do this properly in the care home setting. So, John, over to you.
Thanks. Yeah, so as you just said, this is just a few minutes to let you know that the rapid we're going to do a rapid evaluation, rapid being the word, of oximetry use in care homes and of the kind of barriers and enablers to that use. So what's needed to make it possible to use oximetry well in care homes. So I'll say a little bit more in a moment about what we're doing and how. So go to the next slide, please. And the next one. Great. So just to say that the work we're doing is funded by the National Institute for Health Research. I am John Sussex. I'm from an organisation called RAND Europe, which is a not-for-profit research organisation, and we're part of a National Institute for Health Research funded rapid evaluation centre called BRACE. It's led out of the University of Birmingham. And we're doing this evaluation of oximetry in care homes along with colleagues from the one other rapid evaluation centre funded by the National Institute, and that's known as RESET and is led out of University College London. So you'll see there's quite a long list of names of people involved in the rapid evaluation, both from BRACE, including Birmingham University and RAND Europe, and from RESET, including people from University College London. And just to stress that this is being done through the National Institute, so it's being funded like any other piece of National Institute research. Okay, next slide, please. Just to say that, in essence, what we're hoping to achieve in the evaluation is to understand and share that understanding so that everybody can see how COVID is being tackled, as it were, with pulse oximetry. But beyond that, how pulse oximetry can be used when, as we all hope, COVID is just one of a number of illnesses that people may suffer from, not the one that dominates all our immediate thoughts. And in that slightly longer term future, any condition where oxygen saturation levels are important to monitor, the use of pulse oximeters in care homes in those circumstances too. So it's intended the evaluation will have a longer relevance than the immediate pandemic. And just to say the focus is on how oximeters are being used in care homes all over the country, and in what way can that use be facilitated? Are there barriers that can be removed or reduced? And in particular, is the help that's possible to obtain from different parts of the NHS appropriate in getting through those kinds of questions as well? The perspective is very much from the care home perspective and from particularly managers of care homes. So if I could have the next slide, please. What we're basically going to do is very straightforward. It's a survey which will be sent not directly from the research units, but via an intermediary, so that we're not in any breach of GDPR regulations, which will go, an online survey, which will go to the registered managers of all care homes in England. I very much hope that at least some of you will be able to reply to that. It will keep it short, we'll keep it to the point, but obviously we need people to reply to the survey in order to learn anything. So those of you on this webinar who are from care homes, if you are the manager who this is likely to land with, please respond to the survey when you get it, which is likely to be in March. If you know the manager, please ask them to make sure they respond when they get it. We will be, as well as surveying every care home in the country, undertaking some in-depth interviewing in 6 case study sites, yet to be determined which, but a spread of types of care homes across the country. And by an in-depth interview case study, I mean there will be several interviews at that particular care home and in the people working with that care home in the NHS. The overall study timeframe is to have the whole thing done, written up by the end of May. So we're very much hoping that come June there will be something to show you all of you on this call, and indeed lots of other people, about how oximetry is being used and the resources that are needed to make it possible to use it. So that's really all I wanted to say. So back to you, David.
Great, thank you, John, and pretty much bang on time as well. So 13:33, we're going to move into questions and answers now. So glad we're also joined on the panel with Liz Jones and Emma Self. And Joe, I think you've been monitoring the chat box as we've gone through and may have some questions for us. Do you want to maybe pick out the most common one that's come out first for us to answer?
Yeah, thanks, David. So kind of taking them in order. So there was one at the beginning about terminology of COVID virtual ward versus COVID oximetry at home, and you've put in the chat the table that distinguishes the two. but maybe if you just want to comment a little bit more on that, just for clarity of terminology.
Yeah, so it's a really good point that was made about discharge in particular, and actually discharge into a COVID virtual ward doesn't mean that the hospital responsibility for that particular patient has ended, and actually a better word is transfer. And I think it's a fair point. I think the currency of discharge is one that's been quite helpful in the context, but it is definitely a point around continuing that supervision and making sure it's appropriate, with additional appropriate treatments as well. And as you said, I've posted a table in the chat, which hopefully you can see, which comes from the COVID virtual ward standard operating procedure, which just sets out the differences between a pure COVID oximetry at home service and a pure COVID virtual ward service. Again, as I mentioned, sometimes the distinctions are blurred, but that doesn't matter. I think the main thing is that the person with COVID gets the support they need, whether that's in a COVID virtual ward with more active remote monitoring, clinical supervision, or access to a pulse oximeter, which supports self-monitoring and self-escalation. Thanks, you, Joe.
The next one was just a quick one about how PCNs can get a hold of devices. I think we responded in the chat, so just to let you know that you can access those through your CCGs very easily.
Joe, if it's okay, I might just add a little bit of extra detail around that.
Yep.
So pulse oximeters are available for CCGs and acute trust to request, not directly to GPs or to care homes. The reason for that is that at the start of the programme, we got advice that might incur a VAT liability on care homes or GPs as independent contractors. So we're able to distribute oximeters quickly. So from a request from a CCG or trust, they're normally delivered within 3 working days. So we can get them out fast, and hopefully that mitigates things. But if you get in touch with your primary care network in the first instance, and then they get in touch with their CCG, we are able to distribute oximeters quickly.
David, can I come in as well? Just I think it's really we've kind of recognised the need to kind of distribute more pulse oximeters out. So as you said in your piece, that we've now got kind of more to distribute out to residents, but in some care homes, they might have already purchased pulse oximeters already, and they may have already, and I know in the manner they have, but it's really important to kind of think about the pulse oximeter that you're using, and to make sure that it's EU approved and it's got the EI standard on it, as because there is a little bit of variability in terms of pulse oximeters and how they are regulated, and the ones that we've bought from NHS England are the ones which have the kind of the EU standards on them. And then the other thing is around pulse oximeters is to make sure that you're certain around the decontamination and the cleaning of them, and the maintenance and the use of the batteries. All of those things are on the instruction list when you first get the pulse oximeter. So it's well worth. It's like any piece of kit, reading those instructions when you do get it, and just familiarizing yourself with it. Thanks.
Thanks, Adrian. The next question was around sharing information, so from primary care or CCGs directly into care homes, and any hints and tips on the best way to do that. So I wonder, Alison, perhaps got some comments on that?
My apologies, couldn't get off mute. I think sharing information is really important. As I said, there's a lot of just general information on the Futures NHS website, but most CCGs have local resources that you can actually find out what's happening in your local area. But what we've also thought about with the e-learning is it's a very simple link, and so we could actually share that by texting, perhaps use text from GP systems, or sending it as an email link straight into care homes, particularly if they're on NHS net. And I know Reed might be able to help with that, but as part of the COVID response, a lot of care home providers were given iPads to use in their care homes, and we were discussing whether we could have a link straight into the e-learning module. So lots of different ways, but ask your local PCN. I can just see that Breed's come on, so she might be able to help us more with that, other suggestions.
Very, very happy, obviously, to take any suggestions for what would be useful on the iPads, because that's an open and moving opportunity. So I think if people have got suggestions, popping them in the chat would be really helpful. And I've obviously taken the one about the e-learning, Alison.
Thank you.
Emma, was there something you wanted to add around guidance that's coming out?
Yeah, so we've worked with the care provider sector leads to put together a very short online guide as to how to use pulse oximetry. So it's a visual read rather than the e-learning. It just follows some simple steps, clarifies the difference between the COVID oximetry at home and the COVID virtual ward. The oximetry itself is the same, irrespective of which pathway you sit on, but we're hoping to get that published this week. So it'll be the Care Providers Alliance that will share that with people via email and other links.
Thanks. The next question is around, wasn't really a question, just a comment around learning disability resources. So certainly there's an easy read version of the patient information and a number of other resources that have been developed around COVID that are shared again on the Future NHS site. But again, perhaps if there's any comments around that specifically.
Shall I take? Go on.
Sorry, Adrian, you go ahead and I'll...
Well, I was just going to say, I think this is going to be applied to any kind of care home, whether it's a learning disability or an older age care home. I think the principles are just the same. I think you know, we have to be able to be thinking about capacity decisions as well, and thinking about how to explain what you're doing and how you're using the particular device. And sometimes that's going to be different, nuanced in terms of a resident with learning disabilities or as opposed to a resident, say, with dementia. So I think kind of the application of the pulse oximeter is still important. And I know in one of the learning disability homes in my area, we've been actually using pulse oximetry for a resident who's got a severe learning disability and Down syndrome, who's in the past suffered from aspiration pneumonia. That's kind of where you suck down some of your food into your lungs and it causes an infection. And in order to be able to spot sometimes the deterioration that person might have, we have the staff in the care home have already instituted using oximetry. So it is very much applicable to LD environments. I'm sure Alison's probably got much more information from her role.
Thanks, Adrian. Yes, I co-lead the West of England Learning Disability Collaborative. So we've done quite a lot of work on this, and Breed mentioned Baywater in Gloucester, and they've been doing a lot of work in learning disability homes. And one of the uses that we found was that because the care home staff were actually taking regular observations, they started picking up people who were unwell before they became obviously unwell, and particularly people who weren't able to speak and communicate, and they were able to reduce admissions. So it actually felt really very you know, the carers said they felt really rewarded because they were doing something earlier and supporting their ideas on soft signs. But I also wanted to mention about another issue of monitoring people with a learning disability, because sometimes one of the challenges of people with learning disability is actually not liking having observations done. And so again, what they found with Baywater and the work they did in Gloucester, that by taking observations perhaps once a week, the care home staff got used to it, but also they found that the residents became desensitized. And so perhaps initially they just see the blood pressure cuff and not want it. But if every week somebody had their blood pressure measured, the carer became more confident, but actually the person with a learning disability became more engaged, and they found they became much more engaged in the annual health check. So that was unexpected benefit. And alongside that, there's some work being done in the southwest with pulse oximeters in Torbay, when they're providing pulse oximeters to everybody on the learning disability register with training, because they want to get people with a learning disability used to having their oxygen sats measured. So if they were to get COVID, then they would be more confident about being monitored. And finally, I want to say the videos on our e-learning were actually co-produced with experts by experience from the Learning Disability Group from NHS England. So a big shout out to that team for helping to produce those videos. Sorry, quite a lot on learning disabilities there.
Thanks, Alison. A question about whether this can be used in other long-term conditions, so beyond COVID.
I'll take this one if it's okay. I know Adrian's already posted in the chat, and the answer is, Susan, a definite yes. I think we're largely consumed by COVID, but I think the described as a terrible, it's the silver lining on the terrible cloud that is COVID, is that people are more receptive now to different ways of working. I think some of the changes that we've managed to do in very short order, we've been trying to do across the health and social care system for years, and we've done it really quickly. I think if we can keep that momentum and embrace some of these positive changes, that's the way to go. And long-term conditions are, you know, for the health and social care sector, the biggest, or one of the biggest challenges. So yes, absolutely. We do have in NHS at Home, we do have another area of work which is focused on those other areas. So we're looking at things like blood pressure monitors, flash glucose monitors for people with a learning disability. So there's lots of opportunities, and I can see Breed is keen to come in as well. So Breed.
As I said when earlier, you know, the platforms that we've helped support in care homes measure a plethora of observations, and actually early feedback from some of the care homes was that when they actually had a trend of data, or they could tell when they were having conversations with clinicians and they could tell the story more holistically, or indeed where the clinicians could see the platforms as well and they were looking at the same measurements, it really allowed them to define what care was needed much more readily. And that was not just about COVID, that is about long-term condition management, and all of the platforms can adapt to whatever measures are required based on whatever you need to be measuring for a long-term condition. So I think it's a model of care for the future that is not going to go away. And that's true in the hospital virtual wards. People are looking at how they can be used for other cohorts of patients as well. So yeah.
Thanks. And I wanted to reinforce what you were saying, Breed, because I noticed in the chat there was a question about Restore 2 and how can you encourage carers to use it. And I can understand people thinking, oh, I don't really want to be taking observations because I don't want to have clinical responsibility. And I completely agree. Carers should not be taking clinical responsibility. Clinical responsibility lies with the clinicians, with Adrian and myself. We should make the decisions there. We're not asking you to make those decisions. But if you can imagine when we're on call and I get a call about Mrs. Bloggs who's unwell and I don't know what to do. Do I walk out of surgery? Do I see her at the end of surgery? And I'm always worrying whether I've made the right decision. And therefore, I think carers actually it's not always an easy conversation. But if they phone up and say, Mrs. Bloggs, I'm really worried about her. Her oxygen sats are 93, her blood pressure is 110/70, and her respiratory rate, I'm not expecting everyone to measure it, is 24. Immediately that changes the conversation. And so the carers are empowered. And so that's what we found in the west of England, that by working with our carers, it's become a much more mutual and collaborative way of working, much more enjoyable for us. And also, I like to think we're valuing the carers because they know there's something wrong, but hopefully we're developing that common language, which is really, it's a great way to work when you're working together. So I hope that answers why Restore 2 works. If you look on our website, we've actually got some really supportive stories of the care home managers who found it really helpful.
So I'm going to put several questions together now because I think they're all probably interrelated, and I think this is around training. One about there hasn't been any training in residential care homes. Another question about is there guidance around how often oximetry should be performed, with residents who, regardless of their condition, so kind of the baseline conversation. And again, I think that links in with the work around Restore 2. So perhaps Alison, if you want to just comment on that, and then others chip in.
Thanks. As you say, it depends why you're measuring taking measurements. So in the COVID Oximetry at Home or the COVID virtual ward pathways, it's usually about 3 times a day. And again, we've put that in the e-learning. But if you're just doing it as part of what we call baseline, knowing what's normal for people, it very much depends on what you do in your home. So at our local care home, it's often when the resident first arrives, then you look at that advanced care planning, should you fill out a respect form, but also do baseline observations. What is normal for that person? And quite a lot of homes will repeat it perhaps every month, because that way the carers become confident and the people they're looking after become more used to it. So it's very much, why are you doing it? Is it just part of normal practice and everyone becomes comfortable? Or is it when they're unwell, when you do it much more often? Adrian, I don't know if you've got anything else to add to that.
No, I think that's really relevant. I think it is really useful to have a baseline, and as you were saying, Alison, it's not just for learning disability residents to get used to it. It's also for the residents of any care home to know that this is part of how we're supporting them in the care home, to be able to, as professionals, kind of look after them. And I think that's important. I think in terms of the when someone is COVID positive and how often you're going to be measuring that through the day, I think, and this is, we haven't talked about this on this thing. It's very much part of your workforce in care homes, to be able to support residents, and there's lots of other things that you have to do as well. So I think the importance is to get that balance between what's right for the resident and what's right for kind of the workforce. You have to be, there's lots of things around testing and all the other measures that are going on in the care home. So you, in a way, you've got to be able to be very conscious of that. But I think, as we were kind of saying, getting used to this bit of kit, using it as part of the standard way that we communicate, and working with residents and their families to just understand that point is really important, because and I think the other thing is, we were talking this morning about with Kay, and I don't know whether Kay is still on the chat, but sometimes it's how you position the resident as well that affects their oxygen saturation. So if someone is sitting hunched up in bed, that might affect how much lung expansion they've got and how much of their. So actually there are nuances to using this bit of kit as well, which you can by getting used to it, you can help the staff get used to it and understand that you might want to repeat it 2 or 3 times with them maybe in bed, but then when they're sitting up, so that actually they're getting a better lung expansion, and then taking the best of those 3 readings, rather than just saying one reading is the right reading. Now, all of these are nuances, but I think what you can do is get used to it and get used to using the bit of kit, and then once you're used to it, then you can use it kind of, and then it becomes especially useful when you've got a deteriorating patient. Okay, did you want to come in? Yeah.
I think we've probably answered this within the chat and some of the comments that have already been made, but just to acknowledge the reference to domiciliary care settings, whether there's anything to add.
Yeah, and I think what we wanted to do was, I mean, this is really for all care settings, so it's not just for residential and care homes. Actually, COVID Oximetry at Home is for people receiving domiciliary care and people out in the community as well. So it's very much a program which isn't discriminating against one group. You can access it whether you're in a care home, whether you're receiving care at home, or whether you're in the community having no care at all. You can do it yourself. So we want everyone to have this available to them. I think is the important thing. I think with domiciliary care providers, the training and the packages are just the same for residential care home carers as well. So I would encourage all domiciliary care providers to be using the training materials, the e-learning package as well. I think the thing about people receiving domiciliary care is that, and this I suppose this just applies to the Oximetry at Home programme. We the evaluation that we talked about, that John talked about, unfortunately doesn't extend to domiciliary care in the timescale that we had to be able to look at the evaluation. And with the programme as it is, we couldn't extend that to domiciliary care. That's not to say that in the future we might want to do some work with domiciliary care providers, but just for this short evaluation that we're doing, we have decided to just limit it to care home environments at the moment. But otherwise, domiciliary care, absolutely, people in their own homes are suitable for this type of monitoring.
Okay, the next couple of questions are related to data. So there's one specifically about the data returns that we're making for the COVID oximetry at home. Is the care home's data included in the CCG returns?
So my understanding of this is it's not included directly within the CCG returns, but because we include the NHS number in those CCG returns, we can track that back to postcode. And from knowledge of postcode, we can make an assumption around if somebody's living in a care home. So not directly, but indirectly, yes, we can work that out.
And I think that comes back to perhaps some of the sort of local data reporting and understanding of our own capture of data. Thank you. And the second one was around how often and how well are monitors being used?
I guess there's two levels to that question. I guess a system level, so across the country, we've distributed around about 400,000 oximeters. We're waiting to get management information on the use, so that will give us a sort of patient number, and it also links to the evaluation as well, which John's described the care homes element of that. But we're working with 3 academic partners to evaluate that. I guess on a patient level, and thinking about adherence, I might just invite either Adrian or Alison to answer that question.
I think kind of in terms of patients using it, I mean, my experience is in the community, when people have been supported in using it in the right way, they use it throughout their condition, throughout the terms of COVID in the right way, and they're very kind of, in terms of doing it 3 or 4 times a day, they're recording that and acting on that. I think in a care home setting, I think it goes back to that workforce issue and how well people are trained and how well the supervision is around that. And it's people like Kay and the managers and the who really help with that and help get the staff confident in using it, and then that helps with the adherence to using it in the right number of times. So that's in my limited experience, but I'm sure Alison, probably from an AHSM perspective, will have more.
Yeah, I think it's different whether you're using it in the community or in the care homes. In the care homes, I would recommend that it's done regularly, because what we want to pick up is silent hypoxia when somebody appears well, but their oxygen sats are completely unexpected. So I would recommend in care homes, definitely, if it's 3 times a day, that you do your utmost to do that, which is why on the e-learning we've kind of put a handover sheet to support that. But actually, just being realistic, in the community, what we've found is that if people are on COVID oximetry at home and they're doing their own monitoring, if they're unwell, they cooperate, they're doing it 3 times a day. Adrian's smiling because everybody's seen it. But actually, if they feel well, they forget. And I think we've got to have a degree of pragmatism, because if people are well, then they're not going to be checking if they're looking after themselves. But as soon as they know something's not quite right, then they check it more often. So I think that's probably just a degree of realism.
Human nature, isn't it?
Human nature, that's right. But within the care home sector, I think perhaps we shouldn't be slipping off, because we don't want, because you're monitoring somebody else who hasn't made that decision to not be checked, and we don't. And the whole point is to pick up silent hypoxia. So I would say 3 times a day, work out a way that you can remember to do it.
And I think, you know, we remember to take, or medication is an example, isn't it, Alison? Some people are very good at taking medication. Some people need structures to be able to help them take their medication. It's a little bit like that. But I would say, in terms of this program, it's a fantastic new program in terms of people being empowered to look after their own condition, but also those who can't be empowered, they can't manage to do it themselves, we're helping them to do that. And I think of it in that respect. And I think this is only the start of a bigger program which is going to go through the NHS around using devices at home to be able to support people in whatever long-term condition they have or whatever problem they have. We're going to be getting much more used to using devices, and I think that personalizes care much better. It gives us an ability to say, this is the care for you as an individual in a care home or living in your own home. This is how we can help support you. And I think it's a real shift, isn't it, David, in terms of how we're thinking?
It is. Thank you, Adrian. I'm conscious you've taken us through to 2 o'clock and you've provided the perfect summary. Thank you. So all it's down to me to do is just to thank our speakers, to thank to Bernard, Lauren and Kerry in the background who've helped this run relatively smoothly, very smoothly. And lastly, just to thank you for your time. I hope that's been helpful. I have spotted we haven't answered a couple of your questions, but we'll make sure to do so. Anything else, please do get in touch with us, including if it's useful for us to cover other areas in greater detail. So again, thank you for your time and thanks for everything you're doing.